Dr. Miller, thank you for coming on to my podcast for a second time.
You're
Malika.
welcome.
Actually, you're the first guest to show up twice because the first time we had a technical issue where we only got real good footage um, that lasted only 6 minutes from our 30-minute conversation. But thank you for doing this again.
Practice.
Yeah, now we have practice. Should go a lot smoother. So, Dr. Miller, how would you describe what you've done in the last couple of years? So you've done a residency and now you're a fellow, right?
Yeah.
So it's a general surgery fellowship, residency, and now you're a what type of fellow?
Minimally invasive surgery.
Surgery fellow. Okay. But I think we should go back to the beginning of you just being a medical student. You get exposed to a lot of different specialties, and you specifically chose general surgery. Why general surgery?
Yeah, that's a good question. For one, I've always liked GI, so that was one of my potential fields of interest. But when I was doing my rotations, I hated everything else. There's no way I would have lasted in internal medicine to get to a GI fellowship, and I'm really glad that I nixed that idea. My other area of interest was EM, which definitely didn't want to do that either. So, and I loved surgery. I loved operating and doing everything involving surgery. So that's how I chose.
Okay. So did you just recently complete the general surgery residency? And how did that go?
It was good. So I did my residency in Pennsylvania. I did 6 years. So when I initially applied for residency, I didn't match. So I did a prelim year at the program where I ended up staying and then completed the 5 years. So general surgery residency is 5 years normally. Some are 7 if they include research years, but mine was 5. So then I did the extra year, which is 6.
Okay. And then now is it an extra year for fellowship?
Yeah. So MIS or minimally invasive surgery fellowship is 1 year. It's like the one fellowship that's kind of different at every program that you go. So minimally invasive surgery isn't like a board certified field, such as like colorectal, plastic surgery, vascular surgery, or even trauma. So it's a little bit different, as in like every program is different. So, and there's multiple different like facets of it. So mine is technically advanced GI, which is just minimally invasive surgery, and then it has some bariatrics in it, but it's not a bariatric only program. So some programs are only bariatrics, some are only complex hernia, and then some are only advanced endoscopy. So MIS is kind of a very broad field.
Where? Okay.
So my program, I do a little bit of all of those, which is why I like it.
That's a good summary of everything. I actually didn't even know that. So how was it like residency? How would you describe a day in the life of a surgical resident?
Yeah, so every program is different on like the hours that they, start and end. My program usually, you'd start at 5 a.m. would be the beginning of your shift, and then the end of your shift is 5 p.m. However, you adjust when you come in and when you leave for how many patients you need to see in the morning and like when the work gets done. So it's not like a strict 5 to 5. It can be much longer than that. We had a night float system, meaning like every month there was a set of residents who only covered at night during the week, and then everyone else would cover weekends, like alternating. Versus some general surgery programs have X amount of days call, so like Q3 call, where you're on 24-hour call every 3 days. So every program is different, but mine was a night float system. So your hours are a little bit more predictable, which is good. But yeah, that's kind of how the hours worked.
Okay. And doing like 5 to 5 every day for 5 years must have been very stressful.
Yeah, so not necessarily stressful, but like taxing, I guess. They have like an 80-hour work restriction policy, but whether or not programs follow that is their own prerogative. Residents do lie about their hours, which I don't recommend. But that 5 to 5 can also be shorter if there's co-residents willing to stay in the hospital to cover things if you had something like an appointment to go to. And sorry, you asked what the day in the life would be, but we would start by rounding on the patients on our service and then go to cases in the OR or see consults and stuff like that. So the days are very fluid. It's not like a set, this is what you're doing. It just kind of depends what's on the schedule.
Okay. And when a lot of people think about general surgery, they think that, the resident/surgeon is always in the operating room. They think that that's all you do. You don't see patients because all your patients are, in the operating room sleeping like for surgery. Is that true?
No, so we round on our patients. We either go to the operating room or we go to clinic because you need to see patients in clinic to be able to operate, because otherwise you'd have no one except for people who come to the ER. And then we see consults, whether that's in the ER in the hospital, or some places you go to a different facility. Like there's things called LTACs, which is a long-term acute care facility, or sometimes we'd get called to go there for like PEGs or trachs on long-term residents who needed that. So it's not just operating.
Okay. And you mentioned that you have to round on patients. What does that mean?
Yeah, so you come in the morning, you create a list, look at all the patients you have, did they have any issues overnight, you look at their vitals, labs, everything, and then you go around and see them, see how they're doing, do a physical exam, and make a plan for the day.
Okay. So you did 5 years of that, correct?
Mm-hmm.
Six. Right?
Yes.
6 years, graduated residency. Now, usually people would, want to just become an attending, no more studying, make the big bucks. But you decided to do a fellowship.
Yeah.
Why the fellowship?
I like to torture myself. I'm just kidding. So I was really interested in learning how to do complex hernia repairs and just wanted a little bit more experience. I definitely felt comfortable, after graduating going into practice, but there were some things that I didn't want to teach myself. I kind of wanted to get that extra year of teaching. And so that's why I chose this fellowship, because they'll do a little bit of everything, as well as the complex hernia stuff, which was great. We do a lot of robotic surgery, which I also did in residency, some laparoscopic surgery as well. So that's why I was interested.
And what do you do exactly as a Miss Bar fellow?
So when you say MISBAR, that's just the acronym here, which means minimally invasive surgery / bariatrics. But every day of the month is different. I have a whole schedule because I can't keep track of like which first Monday of the month am I doing what. So I do, a few days a month of bariatric surgeries, which I'll say right now is the volume is much lower because of all the GLP-1s.
What is that?
So weight loss medications that people hear about, usually injectables that help you lose weight. So a lot of people are doing that instead of getting weight loss surgery because it's less invasive. So I do that, and then I do, a few days a month in clinic, whether that's bariatric clinic or general surgery clinic. I do a couple days a month of doing robotic colorectal surgery, a couple days a month of doing advanced endoscopy, and then most days when I'm not doing that other stuff, I'm doing, robotic general surgery, which is usually hernias.
So, that was literally my next question was, what is your favorite thing to do? So it's hernias?
Yeah.
Why hernia?
Because it's not like a cookie cutter surgery, which really no surgery is, but there's so many different facets of it, and it's kind of like a puzzle. Like, what is the best way for me to fix this? What are some extra things I need to do? A lot of what's practice now is optimizing a patient. So preoperatively, you want to make sure they're optimized, meaning lower BMI. You don't want to do it on someone who's majorly obese because high risk of recurrence. Do they smoke? You want to stop smoking? Are they diabetic? You want to get their A1C under control. So it's kind of like a whole story of the patient that you gather and then try to work out a way how you're going to approach the hernia. And then there's so many different ways of how you can fix it. There's so many different meshes that you can use. And hernia surgery used to be like they were doing one operation with this one mesh, and that's how it was done. And like the research in the past like 5 years has exponentially increased. So it's like a growing field. It's very interesting. So that's what I love about it.
So why are these patients getting hernias? What are some causes of hernias?
So some of them are congenital. Some people are just born with like a belly button hernia or umbilical hernia. Inguinal hernias are sometimes congenital, but a lot of the time it's from previous surgery. So they can have an incisional hernia, or they're heavy lifter, you can get a directing linal hernia. So just some types of weight. Yeah.
Okay. And for those that don't know, can you describe what a hernia is?
Sure. So what I tell patients is a hernia is like a hole in the wall. So the abdominal wall, usually when you're talking about ventral or incisional hernias or inguinal hernias, I explain it like it's a hole in the wall. So the best way to fix it usually is to put a piece of mesh to kind of plaster that hole, whether you're closing it or not. And that's like the most simple, fun way. But I'll explain it to them.
And when they do the surgery and you put the mesh in, does the hernia ever come back?
Yeah. So anytime you do a hernia repair, there's always a risk of recurrence. So hernias are kind of a chronic disease because it means they have poor tissue quality that end up with the hernia. So we can do our best. We only found a 100% success rate operation yet. So there's always a risk of recurrence.
Okay. And I just want to share this story of how I met you.
Okay.
So it was, I think, my first week of this surgery rotation, and I was scrubbing into the OR, and then you came because the sink is like it's like a double sink. So I was on this one, and then you came. I think it was to my right one, and I looked at you and I said, "Hey, are you a resident here?" And you said, "No, I'm a fellow, but don't be fooled. I don't know what I'm doing here." So I kind of chuckled at that, and then it ended up that we're going into the same case. So surgeons always scrub in like 2 minutes, and the medical students have to sit there for like 10 minutes to making sure everything's right. So I walk in behind you, and I see that you're on the robot doing the entire surgery from beginning to end. So I wanted to ask you, can you talk more about the robot and how that changed surgery?
Sure. So, back in the way old days, everyone used to do abdominal surgery open, meaning a bigger incision. Then they came out with laparoscopy, I think in the 80s. Correct me if I'm wrong, someone. But that we call straight stick laparoscopic surgery. So, meaning that we use little incisions, put ports in, and then we have instruments that are straight sticks. So we can't like move our wrist, it's like straight. It's hard to do things. You can only like move up and down, side to side. So then they came out with the robot, and the one that we use is Intuitive is the company name. It's Da Vinci robot, and it really changed the game because you're not standing at the bed where you would be if you're doing open or laparoscopic surgery. You're sitting in a console, and so with that, the camera is amazing. You have like 3D vision. It's super magnified, and so you have a really, really great view of like what you're doing. And the instruments that you're using is you can move your wrist, so you have wrist articulation. And right now, the one that we have, you can have up to like 3 arms. So you have the camera port, and then you can have either 2 right hands or two left hands. So you have 3 hands and then the camera, which means you don't necessarily need an assistant like you would if you're doing laparoscopic surgery. So it's great for people who are operating in places where they don't have as much assistance, they don't have PAs, they don't have first assists, because it kind of eliminates that for them. But really the visualization is a game changer, and it really helped with like prostate surgery because they're working so far down on the pelvis, rectal surgery because you're also working really far down in the pelvis, where even if you're doing it open, it's really hard to see, and straight sticks a lot harder too. So yeah, it's great.
Okay. Would hernia repair still be your favorite if you didn't have the robot?
I like open hernia repairs.
Oh, like completely open.
Yeah, like open abdominal wall reconstruction. That's fun. Not as great for patient because they have more pain and higher infection rate and all that stuff. But haven't done a ton of abdominal wall stuff laparoscopically, so I personally wouldn't like that over robotic, but it's just a lot harder.
Okay. And since you're a fellow, are you able to do all these surgeries by yourself, or does there have to be an attending in the room?
Yeah, so technically I'm independently licensed, so I can't operate by myself. And we're in Maryland, so I don't know if I think it's different in different states, but for me, yes, I can technically operate by myself.
Okay. But does the hospital let you operate by yourself, or do they always have to have an attending there just because you're a fellow?
Yeah, technically I can still operate by myself, but with the way the program works, there's always been an attending.
Okay. What would you say is the biggest difference between, fellowship and residency? Or can you touch up on the transition as well between residency and fellowship?
Sure. So residency, I feel like, is a lot more like one step, next step. This is how things work. You know, have a lot of autonomy in regards to like the scheduling and stuff like that. Where versus fellowship, it's more fluid. I feel like I'm not as busy. Like I'm not, working 80 hours a week. Sometimes I can make 'cause I still take call, but it's definitely not as bad. I had more time for like my life, and just a lot more autonomy and decision making and operating and all that. So ultimately, it's better. The transition really wasn't hard because, throughout residency, you gain more autonomy as you go. So you start as an intern where you're just seeing patients, writing notes, not really making a lot of decisions. And then when you're a junior, you start trying to make plans and talk with the chiefs and attendings on what you think we should do. And then by the time you're a chief, you're really running the service by yourself, especially at my hospital. And a lot of the times you're, doing the operation with an attending present because you legally have to. But you're deciding what to do. And, if you're wrong, obviously the attending's going to tell you. But um, really the difference between GPR and fellowship isn't a whole ton in regards to like decision making and operating, but it's just like a more advanced in fellowship, if that makes sense.
Okay. Okay.
It's a higher level.
Yeah, makes sense. There's more responsibility on you as well, right?
Yeah, that's true. Yeah, because I'm an independent,
Right.
surgeon.
Yeah. So how does that dynamic work since you're an independent surgeon, but you still have to kind of, I guess, uh, like be overshadowed by like an attending? Does that dynamic get weird sometimes or?
Um, it is a bit of a transition because you're going from somewhere where you train for so long and you know all the attending's preferences, and that's kind of the way you learn, where you have your own feelings on something. And some are more fluid where they let you do whatever you want, but some are like, oh, no, you have to do it my way or it's my way. So when you get to fellowship, you're working with, unless you stay at the place you were at, which mine didn't have any fellowships, but you're learning like a whole new set of people's preferences. And so I think that's the hardest thing and the way that they like to do things. So there's multiple ways to skin a cat. And so surgery is the same way. There's so many moving parts that like you can have variation in every single one. So I think the hardest part was trying to learn everyone here's preferences and then trying to like respect them and do that. So I think that's the hardest thing. But it's nice because now when I go out into my solo practice, I have so many different options of like what I can do, and then I just cater it to like what I like.
Right, right. And going back to the pretty much Ozempic, right? The medications that you were talking about, did that really have a huge impact on the amount of cases surgeons were having?
Yeah, it seems like it. Like some say their practice is down 30-40%.
Wow.
Which is significant if you only do bariatrics, which some people do. So, and I'm not interested in only doing bariatrics, or I would have tried to go to the bariatric only program. But, a big thing for people who are thinking about going into bariatrics is to get other skills and things that you can do in your practice if this stays as a, kind of permanent decrease, like try to have a medical weight loss clinic with your practice where you do GLP-1s, so you're getting that business as well. Learning, advanced endoscopy for bariatric patients is huge. So like patients have complications, they do happen. So being able to manage those complications instead of sending them to GI who does those procedures is also huge. But I personally think it's a temporary decrease because a lot of people don't realize that they're recommending you stay on these medications lifelong, whether or not you actually need to, I don't know yet. But I mean, would you want to be on an injectable once a week for the rest of your life? I personally wouldn't, versus bariatric surgery is more durable.
Right.
Where there are risks with that, it's less labor intensive in my opinion. So I feel like we're going to see a bounce back of
Right.
surgeries once people realize, or these medications are also expensive. So we can't realistically as a country afford to have all these people on medications because it's very expensive. It'll drain the system. So eventually we're gonna have to figure out a way on like what we're doing here.
Right.
So
So you think this Ozempic is just a temporary hype wave?
potentially, yeah. But, unless they make them like way cheaper or, easier, I feel like is and with the way that obesity is exponentially increasing, like I just don't know. I feel like there's more things that we need to be doing as a society to help combat the disease of obesity versus just doing these medications.
But do you think combating the disease of obesity should be surgery?
No, I think preventative is the best way. So, like incorporating in schools healthier eating and exercise and really like emphasis on these things so that we're preventing obesity so that we're not getting to this point where so many like I can't even remember how much the population's obese, but it's a lot and it's climbing every year. So like what are we gonna get to a point where literally everyone's on a weight loss medication because that's a diet that we're eating. So, diet's also really important. And until we change that, I think we're just gonna continue to see these problems.
Okay. From the bariatric surgeons that you've worked with, do they tell their patients to, have the surgeries, or do they first tell them, why don't you try exercising and all these other uh, methods of losing weight, or have these patients already done those and the surgeon is the last resort?
Right. So, depending on how the practice is set up, here we see them if they've been referred for bariatric surgery and then they need at least 6 months of supervised weight loss. They need to like meet with the dietitians, therapist. Mental health is really important. They need to do all these things to qualify for us to do the surgery. So we're not just, you come in and you have the surgery and then we push you out. And it's like a lifelong thing, right? So like people with bariatric surgery really need to follow up with a bariatric surgeon or someone who's knowledgeable all the, complications you can have. Most importantly, vitamin deficiencies are really important. So it's kind of a lifelong thing. It's really important.
Okay. And something I want to bring up just to get your opinion on. I always hear that women in surgery have a hard time. Have you felt any challenges, being a woman that's a general surgeon, or no?
Yeah, definitely. It's a like thin line of like how you are. Like, you're too nice, people walk all over you. They don't listen to what you say. If you're mean, they categorize you as a B word. Which I don't know if this is a Haley Friday podcast. Um, and sometimes I feel like people just don't listen to me regardless because I'm a woman. Some patients don't want you to examine them because you're a woman, and this happens to males too, especially breast surgery, which I've seen. But I feel like there's definitely some resistance to women in surgery. I know one med student who said like I was interested in surgery, and then my attending is like, well, do you want to have children? So that's a very big thing. I don't have children because I just haven't gotten to that point yet, which don't bother me at all. But it's a real issue for some people, and I feel like some people aren't supportive of women in surgery, and so that's why it's important to get women into surgery because we are more supportive of each other, and But in regards to your question, yes, I do feel like some people, whether it's co-positions, attending when you're in residency or fellowship, or patients, yeah, the way they act is sometimes I feel like different in regards to a woman versus a man.
And let's say there's a woman either in surgery or wanting to do surgery. Do you have any advice for how she can navigate these challenges that she might face?
Yeah, so there's great programs out there for women in surgery, like the Women in Surgery Association, Association of Women Surgeons. They have a conference every year. It's great. Um, there's starting to be like local chapters that support women in surgery. There's Facebook pages that there's like a physicians moms group for kids. Yeah, so there's a lot of like resources. And I feel like most women are supportive if someone reaches out to them. And actually, because I just remembered this, I did a study in residency looking at there's a gender bias, and I did this during laparoscopic cholecystectomies to see if we had a pretty 50-50 split residents and attendings, which was really nice. And it just did thoughtful ways to like simplify the operation, but to see if there was a gender difference in how they like how much autonomy they gave you and what the resident how much autonomy they thought they got, and pretty much there was no difference, especially at our program. It is a very like close knit, like smaller community program. There are studies out there which showed differences for university programs that are larger where you don't get that much of like an intimate connection with your attending. Except for the one group that was different was intern males. But they got a lot more autonomy than the females, and I think that's part of a, somewhat narcissistic.
They thought
And it's-
they
thought they were getting more autonomy than the tenants actually said they were. So
Really?
yeah, and it was like a double-blinded study. So
How did you go about the study?
so it was a little bit subjective. It was survey based because they just didn't have the resources to like observe every single surgery. But the resident filled out the surgery, and the attendings had no idea. But then I talked to the attendings and came up with like a system like how much autonomy they give to like males and females in each year of residency, and like kind of came up with like a scoring, and then they'll paired it.
So generally, you said it was quite equal, right?
Yeah.
Okay.
Yep. Especially at least for our
For that specific program. Okay, that's good to
So
know.
if anyone's interested, it's in the Journal of Surgical Education.
Okay, good to know. Okay. I was gonna ask a question, and then let me check if it's still recording. You can take a quick water break. Okay, everything's good. And the reason why I have to take is because, we had a podcast episode that we did a couple days ago, and it didn't go well. Would you say you're nearing the end of your fellowship right now?
I started in August. It's now like mid-December, so I'm like a third of the way through.
Okay.
I graduate end of July.
Okay. Was there anything that, let's say, you learned in the fellowship that you didn't learn in the residency?
Yeah. Some hernia operations, which is why I wanted to do the fellowship.
Okay.
It's something I've definitely learned and really appreciate, so I can take that into my practice. Just the way, different attendings do things. So like colorectal, learning different techniques in the OR, as well as bariatrics. So interestingly, when I was an intern, we did most of our surgery like open or laparoscopic, really no robotic yet. And then by the time I graduated, we were doing like almost everything robotic, which is, nice because I saw all facets of that. But then I kind of over time lost my laparoscopic skills because we weren't doing as much. So that's another nice thing with this program is we're intending to dose bariatrics will only do gastric bypasses, which is a notoriously difficult surgery because it requires so many steps. She does them laparoscopic to help the fellow get their skills. So that's a really nice thing.
That's very nice. Yeah, I just remember the question that I wanted to ask you, and I just forgot it again. Just said a lot.
Maybe a little right before that.
Yeah, I just remembered. Family. So a lot of medical students, when I talk with them and I say, hey, like, what do you want to do? And they say surgery. And, another student, even me, I'd be like, I've done this before, where I'd be like, but don't you want to have a family, like what you mentioned earlier? Do you think it will be challenging raising a family while being a general surgery, attending at the same time?
As an attending, I think less as rather than like as a resident. So like if I was a female resident with a family, I think it'd be very difficult, unless I had like a stay-at-home husband or something, or a family that lived, like very nearby or with me. Just because the hours are so much, and if your partner also works that much, it'd be very difficult. And the hours that you're working are so early to like potentially so late. So like daycares are only open like certain hours. But I know plenty of like female attendings who had their children either in like the last year of residency or as an attending. who, you know, it's still obviously challenging, but it's a lot easier than if you did it while residency. But I've noticed a ton of male residents who have children in residency, and they usually have, you know, like wives that are doing a lot of the work. So it's definitely different for males versus females having family in residency. But I feel like if you start residency when you're young enough to when you graduate, you can still have children. It's still possible. But that's definitely something to think about for anyone who's thinking about going into surgery.
Okay. And you've done 6 years of residency. You're almost done your fellowship. Do you ever feel imposter syndrome?
Oh yeah, that's why I told you when I met you at the scrub thing.
Oh, right.
Didn't know what I was doing.
Yeah, I guess that's a form of imposter syndrome.
Yeah, definitely. Like all the time. I just, try not to think about it, and you just study and do what you can to learn as much as you can for, the patients. And, like, even though like people tell me, oh, you're so great, like, you know so much, you're so smart, you're good at operating, like I still feel it all the time.
So do you take that ever go away?
I don't know. I mean, I think it's just like maybe partially anxiety. I don't know. I'm a terrible patient, and maybe I should go see a therapist. But I don't know. I feel like a lot of physicians have it. It's well reported. And
Yeah. I mean, I'm a medical student and I have it.
yeah,
I can't even imagine once I'm at your level.
yeah. I mean, it's such a stressful field to be a physician. Like, we're just normal people, like expecting to know so much stuff, have these skills and like never make a mistake. It's a lot. I feel like it's a lot of stress. I think that's where a lot of it comes from. Yeah.
And now that you mentioned stress, I feel like the medical field probably faces the highest levels of stress.
Definitely. Yeah.
Do you think that after all these years, it was worth it?
Yeah, because I love what I do. But I would say, and I would caution people, don't go into it for the wrong reasons. Because if you go into it for the wrong reasons, whether that's med school, like becoming a physician in general, or becoming a surgeon, like you're gonna be one of those people who's like immediately burnt out and you're gonna hate it. And then you're gonna do all this work and you're gonna be miserable, or you're gonna quit and you're gonna have wasted all this time and money and you're gonna go do something else anyway. So if you don't love it, don't do it. Because you can't go into it for the money, because the money's not always going to be there with like decreasing reimbursement rates and like physician salaries, and not something I'm going to get into. But you really have to love it, which I do love it, and I still get burnt out. So it's important to have that work-life balance for sure.
And what do you do to manage burnout?
Yeah, so I'd say I'm a novice at that. But taking the time off to like separate yourself from work and like the hospital is very difficult for me, because I'm like just so attached, and I don't care about what happens to my patients when I'm in the hospital. But separate yourself, take those vacations, take your days off when you have them. Some people really like think working out helps them a lot. I personally like to just like zone out and watch a Netflix series. That helps me like relax. But I'm also kind of an introvert, so it like recharges me. Traveling, I love to hike, things like that, but is not associated with medicine personally for me. So
Do you watch any medical TV shows?
So that's a good question. Before I started residency, and I think in the beginning of residency, I always watched Grey's Anatomy, and I would watch different medical shows, but Grey's Anatomy was always my favorite. And then actually, when COVID happened, I can't remember if I was a second year resident or maybe in my second intern year. I can't remember. But after that, I could not watch medical shows anymore, because they all started portraying COVID in the shows. And I was so like, it was just an awful time in like everyone's lives, especially healthcare workers, that I was like, I can't watch this. Like, I already lived this and endured this torture. I can't watch a show about it. And so then that's when I stopped watching Grey's Anatomy. And like now, if I try to watch a medical show, I just can't. Like, it's just,
They're all ruined for you now?
they're all ruined, because it's like my life is so involved with medicine now, and it's so much like a part of who I am. Like, I need to not watch that because it just adds to part of like burnout. I need, I need
To escape,
from, yeah, exactly.
not think about
Correct. Yeah.
all the procedures that they're doing wrong. Received.
Inaccurate sometimes. It's awful. Yeah.
I just want to quickly talk about COVID. How was COVID while you were doing residency?
Actually awful. So, and every program was different. But so we were a level 1 trauma center, which not all general surgery residencies are. Some of them you will go out and rotate at a level 1 trauma center. So our level 1 trauma center was a lot of blunt geriatric trauma. So that means that majority of our service was patients aged greater than 65. And where I did my residency, we had a lot of people who smoked, who were obese. And so when COVID hit, a lot of our trauma patients ended up either pounding in with COVID or getting COVID in the hospital because everyone had it, and their mortality like skyrocketed, right? So like even without COVID, your mortality is like a geriatric. If you have like a hip fracture or something, your mortality like greatly increases. So then they get COVID and you have a whole like trauma service full of COVID patients, which was just me and a junior resident managing, which was like so many patients. And then we had to manage the medical ICU overflow because we had an internal medicine residency and they like had a cap on how many patients they could see, so they gave them to us. So because we don't have a cap, surgery residents. So I had to do that on top of that, and it was awful. I would like come in, people were actively dying, and I would have to call their family at like 5 a.m. and have a code discussion, and they couldn't even come see their loved ones because of visitor restriction. And so sometimes you're like FaceTiming them on an iPad through the window, and the patient's in the room, and like you're like trying to have like a goal of care discussion. It was so bad. Like I didn't want to do that again. And then like we didn't have the resources, so then you have to like be like, well, should this person go on a ventilator? Which I personally never had to deal with that, but that was a thing. And then because so many people were on ventilators and they got bariatric because their lungs were so stiff from the COVID and being on ventilation for so long, then a lot of people got like pneumothoraxes, which is collapsed lungs. So I was constantly getting called to put in chest tubes as a surgery person. And so it was the most hours I worked throughout residency. It was the most emotionally like grueling and taxing, and so that's why I couldn't watch it. And TV shows it.
Yeah.
And that's why I never want to do that again. So
Wow.
yeah,
I feel like we could have a whole episode just about your experiences with
we
COVID.
could. It was awful. Yeah, definitely have PTSD.
And you mentioned that you did chest tubes. Can you quickly explain what chest tubes are?
Yeah, so if you have a collapsed lung, that means that there's air between your lung and your rib cage. So if you don't evacuate it, it can keep pressing on your lung and eventually cause what's called a tension pneumothorax, where it can cause pressure on your heart and you can die. So you put a tube in the chest to evacuate that air.
Okay.
So
Okay. And does that tube just go through like the ribs?
so ribs are bone, and then you have muscles between them. So those between our
Right, between your ribs. Yep. Okay. Okay. Now just to wrap things up,
sure.
I have a couple rapid fire questions,
Yes.
if you don't mind. Do you have any advice for medical students in their 4th year wanting to apply for surgery residency?
Sure. So, again, definitely make sure that it's something you want to do, because you don't want to get into a surgery residency and then be like, oh, I don't like this. And then you have to try to find a different specialty. I will say it's becoming more and more competitive. And so I'm a DO. So naturally I knew it was going to be harder for me than like a USMD. And I will say, like, don't listen to the people who say that if you get 12 interviews, you're gonna have a problem, because I went on 15 interviews, and this is when, before Zoom times, they were in-person interviews, and I still didn't match, and I ranked all 15 of those programs. And I had like, above average step scores and research and all the things I needed to have. So do as much as you can to make your application as competitive as it can be. do those sub-Is, do well on sub-Is, get those good laparoscopic, but really just make sure it's exactly what you want to do, and then always have the backup plan, whether that's applying for prelim surgery positions, that's becoming more and more of a thing. People are applying for that, as well as categorical positions, so at least you have an in at a program, or apply to a second specialty as a backup. But I will say, if you can think of yourself doing a different specialty than surgery, really think about like if you should be doing surgery, because for me, I couldn't think of myself doing anything else. And so if you can potentially be happier in a field where you could potentially make more money and work less hours, or just work less hours and have less stress, then that's something to consider.
So you really have to be born for surgery. Like nothing, you can't see
I
yourself.
feel like you do, and I feel like part of it's personality and part of it's just like who you are. Yeah.
Any advice for surgical residents that want to go into a fellowship?
Yeah, sure. So, for anyone who doesn't know, general surgery has a bunch of different fellowships off of it, like any residency does. So there's like trauma care, pediatric surgery, plastic surgery, vascular surgery, and then MIS, which I would say, because all the programs are so different, really think about like what your motivation is for doing the fellowship. Because if you think about it, that 1 year you're doing a MIS fellowship is a year that you're losing out on attending, salary, paying back your loans, all that stuff. So it's another year. So really make sure that it's something that you want to do. So for me, I really wanted to learn the complex hernia stuff, which I'm doing, which is great. Or if you want to do bariatric, so you need a fellowship to do that. So that's what I would say. I was kind of under the impression that I would be more competitive for a job if I did a fellowship, which was another reason I did it, which I will say, as someone who's looking for a job right now, is not necessarily true. Because a lot of programs or hospitals are going to acute care surgery jobs where you literally only do ER call, and then you operate on like people who come in. You don't do any elective practice. So to do an MIS fellowship where you're learning all these elective surgeries, to do an acute care surgery job is kind of pointless. So really understand why you're doing it. Because to do an acute care surgery job, usually you don't really need a fellowship. And then, that year of fellowship isn't counted as experience when you go to apply for jobs. Some jobs want like 3+ or however many years plus of experience before they would consider you. And so it's just,
But how do they expect you to have 3+ years?
it's for someone it's not their first job
Okay.
now.
Okay.
So it's very hard to find a job, and I feel like the fellowship doesn't really make you more competitive. So don't use that as your only motivation to do a fellowship.
Okay. And I already asked you this, but I'll ask it in a different way. Is there any other surgical procedure besides a hernia that you like to do?
Yeah, I mean, I like all general surgery, so I really there's no surgery I can think of that I don't want to do, except for like low rectal cancer surgery and like chest esophagus surgery. But anything in the belly, I'm totally fine with. Except for like gynecology surgery.
Okay.
But yeah, that's why I love general surgery. So
I got a couple more on here. Robotic surgery, game changer or overhyped?
game changer. Yeah, lots of people think it's overhyped because it's more expensive and you get similar outcomes to laparoscopic surgery. But a huge thing now is ergonomics for surgeons. So like laparoscopic surgery, you're standing there, you're doing laparoscopic surgery for like hours on end. It's very taxing. Like people have had to have shoulder surgeries from being a surgeon for so many years. So like ergonomics is a big thing. I think it's going to continue to be a very heavily researched thing. And so I think the robot is huge for that, because and even with a robot you can have wrong position where your ergonomics are off and you get injuries from that, but I think it helps a lot. So
Okay, and my last question: what's your OR pop-up zone?
yeah, you didn't ask me this, so I said so I don't have one because I'm used to like the OR music being chosen by the OR staff, but I don't know, it's difficult. I'd say anything from like hip hop barbecue on Pandora playlist.
Okay.
I'm into like indie music, indie pop music, so
Helps you focus.
something from that. No, I just like
Just for fun.
the vibe.
Oh, yeah. Okay, I appreciate your time. Thank you for doing this again.
You're welcome.
We learned a lot from you.
I hope it recorded all. Oh yeah. So.